uh, Dr. Rishi Mohan. He will be talking about interpretation of biomechanical analysis.
Thank you, Dr. Bhati. Thank you for having me on this course, and good afternoon, everyone. So I'm going to carry on forward from where Dr. Bharti has left us with an idea of the overview of how topography can be used and how that can help us detect patients who are susceptible to developing ectasias. So I'm going to talk about another parameter which is not widely discussed but is of late, especially over the last 10 years, become more and more important in assessing patients who are likely to suffer from this condition. I have no proprietary or financial disclosures to make. So it is a rare but serious complication, and we know that the ratio or the incidence used to be fairly high. It has come down over the years with the better established methodologies that are available to us. But amongst the preoperative evaluations, the key is to segregate the high-risk individuals who may experience ectasia after LASIK from the patients who can undergo the procedure safely. Because this complication can occur in patients who may not have any pre-existing clinical evidence of a forme fruste keratoconus. So what are the causes really? A thin stromal bed. This was the case when the earlier keratomes were used, where one could be fairly away from what was the intended thickness of the flap. Undetected topographic abnormalities, and more common when there was only topography available, less common now that tomography is available and we are looking at the posterior curvatures. Biomechanical properties, which I'm going to discuss, where we are talking about the hysteresis and the resistance factors, and the possibility of it being a late stromal melting, where there is an inflammatory process that is suspected to be the problem in ectasia. However, no reports have actually confirmed that there is significant inflammation that could have resulted in ectasia or a corneal melt. In keratoconus, the condition is a little different, and one can see a host of studies which have tried to identify the reasons why ectasia takes place. So there is an increase in collagenylysis and reducible collagen cross-links. There is a loss of keratin sulfate. The highly sulfated keratin sulfate epitopes are much higher. Some keratoconus corneas exhibit an increase in glycosaminoglycans and polyanions, but there is no fundamental difference in the collagen composition in keratoconus as compared to normal individuals. So the current concepts suggest that ectasia development occurs due to a chronic corneal biomechanical decompensation or weakness which is localized to the area of the cone, which results in stromal thinning and protrusion and leads to steepening and increased astigmatism and irregularity. One of the breakthroughs that happened was the advent of devices which could measure corneal biomechanics in vivo. That means one didn't have to actually take them out and do the Young's modulus or elasticity studies. One could actually measure it in a patient who is available to you in the clinic. And the device, the ocular response analyzer, which is the one that I have, and most of my experience is based on that. And the recent one called the Corbis ST are two of the clinically available devices that have allowed this thing to become possible. So it's a several complex biomechanical factors such as plasticity and viscoelasticity may influence the ectasia development. I already spoke of the ORA and the ultra-high-speed Scheimpflug camera imaging, which is the Corbis ST. There are others as well, which are more in the research form, the dynamic corneal imaging, holographic-based interferometric techniques, and now the in vivo Brillouin optical microscopy, which involves the use of specific wavelengths and the interaction with the acoustic waves that exist within the cornea. So this is how an aura signal looks like. And one can see here, essentially both these machines involve the use of what appears to be a conventional non-contact tonometer. And if one understands the way a non-contact tonometer works, the non-contact tonometer sends a very rapid puff of air onto the corneal surface, producing flattening. And there's an optical sensor which picks up exactly when complete flattening takes place, and that is the point where the pressure that is being inserted by the air puff is the same as the pressure inside the eye, and that is called the applanation pressure, or the P1. And as you can see here, the P1 is when that, as the air pressure puff goes up, there's a very rapid spike when applanation happens, but that's where most non-contact tonometers stop. What these machines do is they persist with the air puff and allow the cornea to become concave, and then as the air puff goes down in its intensity, there is the reversal of the cornea. The cornea goes from concave, again going to acquire its convex shape, and in between it again passes through a phase of flatness or applanation, which is called P2. And the difference between P1 and P2 will then be what we call the intraocular pressure or the hysteresis value, and that will be the intraocular pressure which has been compensated for the cornea. So here we can see that the two signals are fairly similar height or amplitude, and they have clean, sharp points, and the raw signal is fairly smooth. So this is the normal signal. But what happens, what starts to happen as the biomechanics of the cornea drop off and you start to get a little bit of keratoconus, and you can see that the IOP-CC is much higher than the IOP-G, which is the Goldman equivalent, and the corneal hysteresis and CRF start to drop below the levels. You can also see that the P2 peak is much lower than the P1 peak, and there is a little bit of bounce because there is now a tremulousness in this cornea, and that leads to a signal bounce before that cornea finally settles down back into its convex shape. All this happens in about 150 or 200 milliseconds, so it's an extremely rapid procedure and works just like a standard NCT. What the ORA has done of late is it has brought in two new parameters. One is what it calls the keratoconus match index. The ORA measures about 37 parameters of the cornea, including the maximum convexity, the area under the curve, the amount of deformation, and so on. And it puts these 37 parameters along this chart, and on the basis of this, it gives you two values. One is called the keratoconus match probability, and the other is called the keratoconus match index. And you can see here in this kind of a graph, the possibility that this patient, or the probability that this patient is normal, is about 89%. There's only a 10% chance that he may be a suspect keratoconus, and very, very little chance that he is anything more than that. And as you can see, the keratoconus match index is way up at the top, which means it is a near normal cornea. So let's talk of the Corvus ST. It records the entire reaction of the cornea to a defined air pulse with a very high-speed shine flow camera taking over 4,300 images per second. And this dynamic corneal response that it measures is then used in the evaluation of the corneal biomechanical response and helps generate similar indices to the ORA. And what it has now done is that it has started to use tomographic techniques and indices coming out from the pentacam and marry the two to get what they call the tomographic biomechanical index, which is a combination of data coming from a pentacam and a combination of the data coming from the Corvus, and put together, as I will show you with some examples, is a far more effective way to detect patients who have the possibility of ectasia. So let's look at this example. Here's the patient with a very asymmetric keratoconus, where one can very clearly see that on the topometry, this is a near normal eye or a normal eye, and this is an extremely advanced keratoconus eye. The left eye anyone can see is keratoconus, and if one looks at the keratoconus match index and the KMP, and which is highlighted here, one will see that it has a very high degree of possibility that there's a very high chance of it being keratoconus, and the KMI match index is very close to being severely keratoconic. But if you look at the left eye, this keratoconus is being missed on the pentacam, because the topographic or tomographic features seem to be of a normal eye. So if one did not have the access to this data of the fellow eye, one would probably miss this keratoconus completely. But look at what happens to this eye when you do the, one looks at the, ये चल नहीं रहा, इसका या तो बैटरी खत्म हो रहा. One can see the chart that is labeled C, that the keratoconus match probability and the KMI are extremely skewed to the right, which tells us that the biomechanical indices of this patient would suggest that this patient has a keratoconus. So every now and then, you're going to come across a patient who will have normal or near normal pentacams, and one would think that, yeah, this patient should be safe. You put them onto a biomechanical measuring device, either the Corvus ST or the Aura, and you'll find that they come up with these numbers which will actually essentially make you say no to this patient. If one looks at the Corvus ST, similarly, there are these three displays, and if you look at the three graphs at the bottom here, you see the CBI, which is the corneal or the Corvus biomechanical index, and the Bellin-Ambrosio display, and the TBI, which is the combination of the two. Here there's a patient who has an obvious keratoconus, as can be seen on the maps. The CBI is very high. The Bellin-Ambrosio display is also very high. Thank you. And the TBI here also is very high. So there is no problem in diagnosing an ectasia or a risk to ectasia in this patient. But as one goes to a patient with better looking topographies, then you can find that the CBI has started to drop off, the BAD has started to drop off, and the TBI on the other hand is still very high. So when you marry the two, the collective data that you get from both the machines suggests that this patient has a very high possibility of getting an ectasia. So to sum it up, mild ectatic cases typically are at high risk for iatrogenic progressive correct ectasia if an additional biomechanical weakening is induced, which means that patients with very borderline changes by themselves are likely to not suffer through life, but if you give them a biomechanical insult, like a LASIK or even a PRK for that matter, they're likely to become unstable and develop an ectasia. Topography and corneal tomography have increased our ability to identify ectasia at their earlier stages, especially of late tomography more than topography, because of the fact that we are now looking at thickness profiles and the posterior float. And despite the continued evolution of shape analysis, direct in vivo clinical biomechanical measurement is essential for augmenting the specificity and sensitivity for identifying cases with mild disease and for characterizing the susceptibility for ectasia progression. So this is really the key message, that the advent of these biomechanical devices is giving us a lot of additional information, which is from a biomechanical point of view missing in just looking at topographic or tomographic or optical maps.